All India Society for giving me the opportunity. I'm going to talk about approach to a patient with nystagmus. The most important point is that if you see a patient with nystagmus, would there be any clinical or are there any clinical signs which you look at to say that this nystagmus would require further workup? So we're not going to talk about management about nystagmus. These are 5 questions that you'll ask yourself if you see a patient with nystagmus. The most important question is that is it present in primary gaze or it is brought about only when the patient looks to the right, left, up or down. Second, what is the direction of movement? Is it horizontal, vertical, torsional or mixed? Is it jerk or pendular? Jerk is where you have a fast waist, pendular is where the eyes move like a clock. What happens to nystagmus when patient looks to the right, left, up and down, and what happens when the patient converges? This I have converted into my own algorithm. I have not published it, but I think it works. So the first question is A, absent in primary gaze. So there are 2 possibilities. Absent in primary gaze, nystagmus which comes about when the patient is not looking straight can be physiological. That's called end point or gaze ending nystagmus. This is right at the end of the gaze. It is generally transient. So patient looks to the extreme right, there will be some movement which will be transient, which will be low amplitude and it will settle down. So you don't require to do anything with this. Versus a nystagmus which I'll show here hopefully, where you'll find that the nystagmus is patient looking straight, no nystagmus. Now the patient looks to her left and there's a nystagmus which is starting before the end of the gaze. So the difference here is that this is starting before even the gaze of the end of the gaze is reached. This is called gaze evoked nystagmus. Now in most instances gaze evoked nystagmus would require further workup because these patients can be harboring problem in cerebellum. So first A, absent in primary gaze, 2 possibilities. Is it because of is it physiological, which is gaze ending nystagmus, or is it a gaze evoked nystagmus which will require further workup? These are probable causes, as I said, enough for us to remember that it can be a cerebellar problem. The second feature is this nystagmus vertical? Are the eyes bouncing up and down? This video is not playing, so I'll show you the other one. This was supposed to be a down beating nystagmus where a patient looks straight and nystagmus, the eyes will move like this. So that is a fast phase towards the feet. Now this in all probability is, the commonest cause of a downbeating nystagmus is Arnold-Chiari malformation where there is a herniation of cerebellum through foramen magnum. There are other causes like drug toxicity or syringomyelia. This is another example of a bouncing up and down, which is an upbeating nystagmus. You see here the fast phase is to the up. So this is an upbeating nystagmus, vertical nystagmus. The point I want to make here is that any vertical nystagmus would require investigation. So that was a example of an upbeating nystagmus. Generally, again, the lesion would localize to cerebellum or lower brainstem. So that is A, absent in primary gaze. B, bouncing up and down. Bouncing up and down, you have to neuroimage even if patient is asymptomatic, because in all probability it is likely to be a problem with brainstem or cerebellum, except the exception would be in children. Children, especially born with retinal degeneration, can sometimes show a vertical movement. So if you can explain why this child is having a nystagmus, maybe the neuroimaging is not required. C is clock. The eyes moving like a pendulum, and I think I have a video for this as well. And this is an example of a pendular nystagmus where you say that eyes are moving like a clock. Now this was also called, in the past this was called sensory nystagmus. This patient, she's staying in down south in Tamil Nadu, so there is an albinism. So the patient developed this nystagmus because of foveal hyperplasia or optic nerve hyperplasia, which albinism would be associated with. So in most instances, pendular nystagmus is where you look at the fundus very carefully to say, is there any cone dystrophy, congenital toxoplasma scar which causes this kind of pendular nystagmus? Though, if the patient says that this nystagmus was not present or you cannot explain as to why this patient is having pendular nystagmus, always look at the palate. Pendular nystagmus can be associated with oculopalatal tremor, which can again be a sign of something going on in brainstem. D is direction change, and this is important for postgraduate for you to explain that these patients. So you see, this is a left beating nystagmus. This is a horizontal nystagmus. You see, it becomes faster when the patient looks to the left. And what happens when the patient looks to the right? So when it reaches the right gaze, the nystagmus settles down. This is called null point. And this is one of the important features of infantile or congenital nystagmus, where patient will exhibit this null point. So that's about D. Infantile nystagmus. These are, as described in the textbook, these are the features of congenital or infantile nystagmus. They are asymptomatic. They are mainly jerk, though they can have a pendular or torsional component as well. There is a null zone which is present. When the patient converges, this intensity goes down, and it will increase when the patient is fixating. E is each to its own, and I'll show an example of a seesaw nystagmus. You see here, seesaw nystagmus, one eye goes up and intorts, the other eye goes down and extorts, and this cycle keeps repeating. This is a feature of a chiasmal compression. So, A, B, C, D, E, absent in primary case, bouncing up and down, pendular, look at the palate, direction change, generally this will give you a clue about infantile nystagmus, and unilateral or disjugate nystagmus. To example, one I showed you the seesaw nystagmus, other can be in dorsal midbrain syndrome. Patient can have both eyes doing its own thing. Nystagmus by definition is a bilateral problem. I'll end with showing you this particular unfortunate little kid who actually had a unilateral nystagmus. Unilateral nystagmus can rarely be seen in, let's say, patients who have a dense amblyopia. Unfortunately, I don't have the video there, but so dense amblyopia patient can have just eye which has amblyopia can have a vertical movement. It's called Hyman-Belchowski phenomena. So that kid was diagnosed as having as having Hyman-Belchowski phenomena. But any nystagmus, what we learned from that case is that any nystagmus always make the patient to look right, left, up and down. This patient, when he started looking up, we could demonstrate a seesaw nystagmus. He underwent neuroimaging and he was found to have large craniopharyngioma. But 6 months were lost because he was treated as a patient with dense amblyopia and was given a patching. So when 6 months later we discovered that it was not Hyman-Belchowski phenomena but a seesaw nystagmus, he underwent a surgery for craniopharyngioma, but unfortunately he did not survive the surgery. So that's the importance of knowing how to make sure that we examine a nystagmus and rule out a serious neurological conditions. Thank you so much.